everybody. Good evening and welcome. It is that time again. It is 5 o'clock Central Time, which means 6 o'clock on the East Coast. That higher order math gets me every time. 4 o'clock in the Mountain Time and 3 o'clock on the West Coast. And it is time for Fertility with Fink. I am Dr. Randy Fink from New Life Fertility in Pensacola, Florida. And it is a pleasure to be here as we are every Tuesday evening at this time. A very special good evening to everybody who has been able to join us so far. And a warm welcome to all those who are here for the first time. We come together every week here and share with each other all the things that are important in our lives, and that is the making of family and all things about women's health, where we have the chance to ask questions, to be heard, and to talk about all those feelings that we have about these very difficult times that we face in terms of adding to our families. A very special hello to Shada. Thank you for that niceness there. And to Christina in Miami. Thank you for being there. Sharmila, as always, thank you for joining. You are the first one here tonight. And thanks as always for being here. Hey to Jennifer, it looks like AF McDwyer. Nurtured Shanna, hello there. CC, aka Pinky, hello to you. We've got Jennifer Sydney, my dear friend Sydney from Colorado Springs, one of our wonderful embryologists I used to work with. Thank you so much for being here tonight. It is a pleasure to see you as always. We've got Ashley Huffing. We've got Angela Sack. Good to see you as always. And we've got our friends over here on Facebook. Hey to Erica. So we've got a couple of different feeds. We've got Facebook and YouTube and LinkedIn right over here. We've got a couple of different Instagram sites. And so please throw your questions my way. If we can't get to them during the next hour, feel free to email to me. And that's at askfertilitywithfink@firstfertility.com. That's askfertilitywithfink@firstfertility.com. And let's dive right in, shall we, to all those things that are important. First of all, I want to say, give a special nod out to Shanna this evening. As always, thank you for being here. And our hearts go out to you tonight, because just in the last couple of weeks, we shared with you the joy of understanding that you had finally achieved that positive pregnancy test after so long of trying. And we are all heartbroken tonight to know that the pregnancy did not continue growing. And after going through such a hard time to get pregnant, my observation was that it is a cruel thing indeed when we find out that our pregnancies are not continuing. You know, after dealing with fertility problems and jumping through the hoops and doing everything right, doing everything the way it was supposed to be done, looking at the science of infertility and treating 100% and giving, really even 200% of ourselves to getting pregnant, then to find out the pregnancy is not growing is really a cruel twist, and our hearts go out to you this evening. Shana asked the question. She said, well, my OB doctor asked if the fertility clinic had done an evaluation to see whether the chromosomes were compatible between my husband and myself. And she said her answer was, I'm not sure. And the question was, well, why don't fertility clinics routinely do something like this? And so, it becomes there's a little bit of a misunderstanding with what that truly means. So there isn't a test that you can do to say, well, gosh, is your sperm and egg, are the sperm and the egg compatible? There is no test we can do to say sperm and egg are not compatible with one another. Really, what I think the OB was talking about there was, have you done genetic or chromosomal testing, which is looking at your karyotypes? And that's where we draw a tube of your blood to see what kind of chromosomes each of you brings to the table. So we know that a male should be of 46 XY, and a female should be a 46XX. Really, the question that was being asked there is, do you have something that's called a translocation? Is there a chromosomal problem that is manifest in the offspring? So what's called a balanced translocation is just what it sounds like. There's balance, there's a little replacement of one piece of chromosome with another, but ultimately they balance out. And therefore, in us, we may not see any effect from that, but that can be passed on into our offspring and become what's known as an unbalanced translocation, which is where the chromosomes basically go crazy and things don't work anymore. That is part of the evaluation that we do in folks who have had recurrent pregnancy loss. We want to look at chromosomes from mom and chromosomes from dad. But routinely testing chromosomes from every couple is not something that is particularly worthwhile, because the incidence of those translocations is fortunately relatively low, and the test is relatively expensive. And so a single miscarriage is usually thought to be an embryo related issue. In most cases, it's a chromosomal or a genetic issue. Now, in your case, Shanna, I believe that you had euploid or chromosomally normal tested embryos. Well, that can tell us that, gosh, the chromosomes are normal, but it doesn't say anything about the millions of little biochemical processes that have to take place within that embryo in order for the embryo to continue to grow. So the thinking is that something probably went wrong in one of those things, and that's what caused the embryo to stop. Once we look and we see the heartbeat, we know that 95% of those pregnancies continue on. In your case, you looked and you saw the heartbeat. So again, it makes it that much more cruel and unfair that you were in that 95th percentile, but yet something happened and went wrong. The issue of chromosomes is not one, again, that is routinely tested, because usually it doesn't prove to be a problem. And in a single miscarriage, I wouldn't necessarily consider that to be something that's a large part of the issue. However, it is very easy to test that. It's called a peripheral blood karyotype. It's just a tube of blood that comes from your arm, and it's very easy to test and make sure that the chromosomes are normal. But to say that it's a question of chromosomal compatibility between partners, like, oh, the sperm just doesn't like the egg, they're not compatible with one another, isn't really a thing. So Shanna, again, our hearts go out to you. My heart is broken for you this evening, and happier times ahead, my friend. So let's see what else we got going on here. Erica asks, it's great to see you. Thank you. Appreciate you being here. In an IVF, letrozole, and menopur cycle here, is it normal for the progesterone level to fluctuate? I'm on 1 ml of progesterone in oil daily. At 5 weeks, it was 120. At 6 and 5 or 7 weeks, at 6 weeks, it was 56. 7 weeks today, it's 26, worrying about the fluctuation and the decline. So, so I guess what you're saying, you did an IVF, letrozole, and menopur cycle, which is a kind of a cumbersome way to do a natural type cycle. And in a natural type cycle, where you were given menopur in order to make sure that you were going to ovulate so that you could create your own progesterone. In that scenario, you really shouldn't need your own progesterone. You shouldn't need, rather, progesterone in oil. So getting the PIO is probably just gravy. And yes, we do see that those progesterone levels fluctuate, because some of that progesterone is coming from your own corpus luteum. So that's coming from your ovary where you released your egg, whereas the rest of it is coming from the injection. So some of what you're going to see there may depend on the time of day that you're checking it, because you're making your own and you're getting a shot. If you get a shot and test that blood shortly thereafter, you're going to have a much higher level. So really what we know, as long as that progesterone is we generally say above a level of a 10 for a natural cycle or above a 20 for a medicated cycle, we consider that to be adequate levels of progesterone. So yes, fluctuation is normal, and it really doesn't change the outcome so much to see that kind of fluctuation. So even continuing to check it is probably not something necessarily that you have to do. As long as you're getting that minimum level, Erica, then you're in good shape. And fingers crossed, congratulations on the positive beta. That is wonderful news. You know, your placenta will take over for making the progesterone by about 9 weeks. So usually we stay on extra progesterone if we have you on that until about 10 weeks of pregnancy, so that we're sure that the placenta is making enough. Congratulations and fingers crossed there for sure. Angela Sachs says, what would be a reason for estrogen levels to go down during stimulations? Do you increase Menopur when you start an antagonist such as Centratide? So asking a couple of things there. She says, my old clinic did that, but I'm at CNY now, and CNY does not. So the thought was that once you start an antagonist medication, and an antagonist's job is to stop you from releasing your egg. We want to keep you from ovulating prematurely because we don't want you to let those eggs go until we're ready to come get them. So there really used to be some thought that once you start the antagonist, it may slow the growth of your eggs, or rather of your follicles. You do not necessarily need to increase your stimulation at that point. There are some protocols where they don't actually even start Menopur as a secondary agent until they start the antagonist. And so that's one way to do it. But, you know, there are many different ways to go about stimulating cycles. And there has never been evidence to say that one is necessarily better than the other. So your old practice used to give you extra Menopur to continue to feed those follicles once you started the antagonist. However, the data says it really probably doesn't make a whole lot of difference. So I typically do not do that. However, what's a little different about the way I practice now is that the physician is following every single IVF cycle and every single data point in your IVF cycle. So if it looks like things are slowing down, or if your hormone levels would dictate it, then we will change your dosing midstream. We may increase it, more commonly increase it. Sometimes we say, gosh, you're going a little too fast, let's slow it down, decrease it. But we're involved with making those decisions every step of the way. In some larger practices, that's really not possible with differing people who are managing your cycle there. So why might the estrogen levels go down? Well, it may have been that you have, some of the follicles that you were growing, that you had recruited may have stopped growing. It may have been that they stopped growing as fast. If you are using letrozole in a cycle, we would expect your estradiol to be artificially low. And so using estradiol as a measurement in that scenario is really not so useful because the number is blunted. And that's what letrozole does. It lowers your estrogen levels so that your brain hears that, your pituitary gland, and says, make me more FSH, which is going to recruit more eggs. So that's probably the reason I think behind you there. Thanks so much for that question. Do appreciate it. Oh, what else we got going on here tonight? Which is the best process you suggest for induction? And Sharmila is currently pregnant and is really asking about labor induction. If you remember from weeks gone by here, we've talked about induction of labor. Typically, OBs do not want to induce labor before about 39 weeks of gestation. So that's typically the week before your due date. And if your cervix is favorable at that point, meaning to say it has softened up, it has thinned out, and it may be starting to get dilated, and that's what we call a favorable cervix, then we know that by 39 weeks, it really doesn't add anything to your pregnancy to continue to stay pregnant. So in that scenario, we would say if you would like to be induced, let's go ahead and get you delivered, because the longer you stay pregnant, the greater the theoretical risk you have, because remember, your placenta is an organ with a fixed lifespan. The reason that a due date is at 40 weeks is because the blood flow through the placenta starts to diminish sometime after that point, and that's because the placenta is aging. And then that, of course, puts the pregnancy at risk. So depending really, Sharmila, on what your cervix is doing. So if your cervix is dilated enough, then we can do something like stripping your membranes. Stripping the membranes is where we place fingers inside to check the cervix, and it literally looks like that. So I know my 2 fingers here, this is 3 centimeters dilated, but if we put our fingers in and literally stretch out the cervix there, start to separate the membranes from the way they are kind of attached on that side of the cervix, that starts a cascade of a chemical in your body known as prostaglandin, and prostaglandin will ultimately cause you to go into labor. So if we strip your membranes and then you go home and get another deposit of prostaglandin, which is having sex, and we talked about that last week, and you're saying to yourself, wait, I missed a talk about sex? Where was I? Then that is often enough to put you into labor. Now, if we have to induce your labor for some reason, so let's say that we find your blood pressure is high and things are not going well, it's time to be delivered for obstetric indications, then we may have to ripen your cervix and make it more ready to be able to open up. Cervical ripening is most commonly accomplished by using a prostaglandin medication, and that's something that's called misoprostol, or the brand name is Cytotec. Cytotec is a pill. It's a medication that's actually used to treat ulcers in the stomach. It coats the stomach. It kind of soothes the stomach. It decreases the prostaglandin in the stomach, but or rather, it adds prostaglandin in the stomach, and so it does the same thing in the cervix. It helps to start to break down some of those fibers. It helps to get you closer to the onset of labor itself. That is usually a very effective method of getting into labor, using Cytotec to ripen the cervix. So classically, a labor induction is when we give you oxytocin or Pitocin, which is the synthetic form of the chemical that your body, your pituitary gland, naturally makes, oxytocin, to cause your contractions. But if your uterus starts contracting like labor, and the cervix isn't ripened enough to receive those contractions, it takes things an awful lot longer, and you risk what we'll call a failed induction. That is, you contract and you contract and you contract, but your cervix never changes. So ripening the cervix is really the best process and the best place to start, Sharmila. Hi to Tiffany and Little Oak, Florida girl. Nice to see you this evening. Earth Girl Peace, thank you as always for being here. Florida Girl 86 asks, is 3 months of Lupron needed for mild adenomyosis and endometriosis, or does 2 months work just as well? So the data from that comes from the treatment of endometriosis. And the way we know this is because we can do a test in the uterine lining for endometriosis. And that test is known, it's looking for a marker that you might have heard me talk about before. It's called BCL6. So this goes by the trade name of Receptiva. And Receptiva is a test. It's a little endometrial biopsy done at a specific time during the cycle, where we suck a little piece of tissue out, and they can test this tissue for the BCL6 marker. If that marker is positive, it is presumed to be because of endometriosis. And in that scenario, we know that the presence of that marker will dramatically decrease the success of an embryo transfer. So let's say that we have a euploid embryo. We know that that euploid embryo should give you a 65% probability of pregnancy, right? So that's best we can offer, really with IVF. In the presence of a positive BCL6, that 65% number drops down to less than about 10%. So it's a very significant effect on the embryo. That's one of the ways that we believe endometriosis is said to have an effect on keeping people from getting pregnant. Well, so if we suppress that endometriosis for 60 days, and that's what the data says, 60 days, that's 2 months, then we know that we can take that 10% number and increase it all the way back up to that 65% number. So 8 weeks is really all it takes. As it pertains to adenomyosis, and adenomyosis is the process by which the glandular lining of the uterus, and remember, what is the uterus? It's a big piece of muscle. That muscle is designed to do one thing. It's designed to squeeze a baby out when that time comes. But inside that muscle is a glandular lining. And that lining's job is to become a nice, spongy, warm, juicy place for a baby to implant. Adenomyosis occurs when that spongy, warm, juicy glandular lining dives down into the muscle. And when it goes into the muscle, it can have an effect on the blood flow to the uterus and on the way the uterus functions in general. It can change the endometrium. So we know that suppressing adenomyosis hormonally with the same medication, with Lupron, can have a similar effect to improving pregnancy outcomes. Unfortunately, it hasn't been studied specifically as to how much time is needed to suppress most cases of adenomyosis. So in my opinion, Florida girl, I think 2 months probably works just as well as the 3 months. So where does the 3-month number come from? Well, it comes from the dose of Depo-Lupron. And Depo-Lupron has a couple different ways you can take it. So regular old Lupron is a daily dose, means you got to get a shot every single day. Depo means it's a long-acting medication. So if you get Depo-Lupron, there's a 1-month Depo-Lupron dose, and there is a 3-month Depo-Lupron dose. So if you get the 3-month dose, it's going to work for all 3 months. Is there a problem doing it for 3 months? No, absolutely not. We know from endometriosis that you don't need all 3 months, you only need 2 months. But sometimes people will say, well, I'm going to get, maybe it's for cost reasons, maybe it's for insurance reasons. They may find that, well, I'm going to take the 3-month Depo shot because it's going to be cheaper than getting 2 of the 1-month shots. Maybe that, but where does the 3-month number come from? Because 1 shot of Depo-Lupron can last you for up to 3 months in that dose. So that's kind of where that comes from. I do think 2 months is probably just as adequate, but if you've got that 3-month version of it, absolutely go ahead and do it. What's the downside of Depo-Provera aside from cost? Well, the biggest downside is that it feels like hell. It just may not feel very good because literally what it's doing is that it's pulling the plug on your hormones. So it's putting you into a temporary menopause. What can you expect from that? You can expect to have menopausal symptoms. That's hot flashes and night sweats, some vaginal dryness, some leg cramps, some mood changes. We can manage these side effects. There are things that we can do, some add back hormone that we can do to try to minimize those side effects. But really, the downside to 3 months instead of 2 is purely one of having to deal with the side effects, having to cope with those side effects. The other issue with using long-term Lupron is that what's one of those things that happens to women in the menopause, and that is osteoporosis. We start to lose bone mineral density. Now, at 3 months, I would not expect there to be a significant loss in bone mineral density, certainly no more significant than you would see at the 2-month mark. But prolonged use of a what's known as a GnRH agonist like Depo-Lupron can result in bone loss. So that's another reason that I'd say the shortest amount of time possible is really probably the best bet. Let's see. Little Oak says, how is a modified natural transfer different from a regular FET? I think that's a great question. So let's talk about embryo transfer. We all know that the process of egg retrieval is one where you get stimulated, make as many eggs as you can get. So, under normal circumstances, your ovaries release one egg per month when you ovulate. So that means you ovulate about 12 times a year. Well, if we can maximize the number of eggs that we get in any one sitting, if you get 12 eggs in one day, you just got a whole year's worth of egg. And that's kind of the way to think about it. Those eggs go to the lab, they make embryos, and then it comes time for embryo transfer. There's a fresh transfer. A fresh transfer is when the embryo goes back inside of you the same cycle that embryo is made. Now, that's not always a very good idea. There are some practices that do not do fresh transfers because traditionally the success rate of fresh transfers is going to be lower than the success rate of a frozen embryo transfer. And why is that? Well, that's because your body has really been in egg making mode. It's been really paying attention on how to make eggs. So going from making eggs to making embryos may be something that it just hasn't really figured out how to master. So we know that you may just do better by making your embryos, freezing them, which stops them in time and letting your body recover. And then you come back another cycle and you do a frozen embryo transfer, which is where we thaw the embryo and place it back inside of you. Now, how do we go about that? Well, two fundamentally different ways. In a medicated or a standard or what we call a programmed cycle, we give you all the hormone that your body needs. We stop your body from making its own hormone because we want to control every aspect of what's going on with your hormones. So we give you estrogen, and that estrogen builds up your uterine lining. And then we give you progesterone. And the progesterone tells that lining, start to get ready to take in an embryo, and then we place the embryo inside, and we keep you on that progesterone to allow the pregnancy to go forward. And that is a standard medicated cycle. We're giving you the estrogen and progesterone. Well, in a natural cycle, instead of giving you those hormones from the outside, we're letting your body take front seat to make those hormones. So in a modified natural cycle, we give you some ovulation induction to make sure that you're going to release, that you're going to build up an egg. As that egg grows, that's where your estrogen comes from. There are some little cells that line around the follicle where the egg lives. Those are called granulosa cells, and that makes your own estrogen. As you make your own estrogen, your lining gets thicker. When we see that egg has reached a mature size, we can trigger your ovulation, which tells the ovary to release the egg. And when the egg leaves, it's like a car leaving a garage. It leaves behind an empty garage, but that little garage becomes a progesterone making factory. And that is where you get your progesterone. And so then you don't have to do the progesterone in oil because your body's making its own progesterone. Now, normally in that scenario, we will give you some extra progesterone, usually vaginally, in order to just support the local environment of the endometrium. So that's the difference between a medicated cycle and a natural cycle. In the medicated cycle, we are giving you the hormones, and in a natural cycle, your body is making those hormones on its own. Different people have different opinions on what works best. Still in the United States, about 85%, or rather about 80% or so of embryo transfer cycles are medicated cycles because old habits die hard. All the evidence has been on medicated cycles. This is what they've been doing since IVF was invented. And it just makes sense that we want to control every aspect of your hormones then. But there's some later data that says that, well, hold on a minute, that when you use your own hormones, uh, the outcomes are at least equivalent. They're just as good, and some studies even show that they're better. We know that in natural cycles there is a slightly lower risk for certain types of pregnancy complications. Specifically, those are blood pressure type complications in pregnancy. So there is really something to be said for a natural or a modified natural cycle. Still, some practices don't do them because they're just so used to being able to control all the variables. So hopefully, Little Oak, that answers your question there. And a follow-up to that, how do you feel about a 38-year-old female transferring 2 embryos versus 1 embryo? Well, at 38, you're kind of in the gray zone there of what the ASRM says. And it kind of depends on, well, you're talking about blastocyst embryos, or are they day 3, or what we call cleavage stage embryos? And by the same token, are they tested embryos? Because if they are euploid or tested embryos, 100%, I would say you want to transfer 1 embryo. If it's a day 3 embryo, I think you're fine, really, at most cases, to transfer 2 of them at 38. So the goal with the guidelines on embryo transfer are that we want you to have 1 healthy baby at a time, because having a multiple gestation, there are some people who come and say, I just really want to have twins. And we say, okay, but we don't want you to have twins because the risk is so much higher with a twin pregnancy. There is a higher risk for preterm delivery, which is really kind of the big thing. Prolonged NICU stays, birth defects, lifelong disabilities, autism. The list really does kind of go on. So we want you having 1 healthy baby at a time. And that's really why the guidelines exist, because statistically, what is more likely to happen, let's say that you're 21 years old and you want to put into 2 blast embryos, odds are pretty high that those embryos are going to be normal and that you're going to have a multiple gestation pregnancy. And again, that's something that we're just trying to avoid. So I would feel okay about it there, Little Oak, I think. But again, depending on what type of embryos you have. Shada shares that this process is very frustrating and that she is indeed exhausted. And I think we can all appreciate that, Shada. It is a grueling roller coaster ride, is it not? I don't want to share too much of your journey, but I will say that it's very difficult when you have euploid embryos, and euploid embryos don't stick because they're supposed to. Right now, they don't always. We know that with a single euploid embryo, we would expect a 65% live birth rate. With 2 euploid embryos, meaning to say in successive transfers, we're up to about we're in the high 80s as far as percentile of successfully achieving live birth. And by the time you're at embryo number 3, you are at a 95% chance of that live birth. The problem is that when you're placing euploid or chromosomally normal embryos inside, and something about them doesn't work, you sit there scratching your head and wondering and worrying, what else is wrong with me? Why is this not working the way it's supposed to? And I will say that is one of the more frustrating problems that we have to face as physicians dealing with IVF. And that's when we are able to make euploid chromosomally normal embryos, which we then place back inside of you, and something happens where they don't stick when we have a high expectation we will. So there's a whole kind of workup that's involved with that, and I certainly think it's worth pursuing. But there is no question that roller coaster ride is one that you would really rather not be on, because it's painful. It hurts the heart. And I will tell you, Shada, that it hurts the heart also of all those who know you, who experience it with you. I think as a community, We stand together and celebrate when one of our members gets pregnant, but we also grieve the losses when they don't. Shada, very much so, our thoughts are with you. Hello to Zaneta in Miami. Thank you for being here. Is LDN or low dose naltrexone okay to take throughout pregnancy? I know I've talked to you before about the LDN protocol. So, low dose naltrexone is a medication that is designed to increase your endorphin levels and is said to have a beneficial effect on both suppressing abnormal immune response and promoting normal immune response. LDN or low dose naltrexone has not been well studied in pregnancy. There are some studies that say that it's fine. It likely does not cause harm. There is no reason to believe it causes harm. The question is does it help to stay on it throughout a pregnancy? And that's a harder one to ask. There are certain practices who say there is no reason to stop taking your low dose naltrexone. Given that it doesn't harm anything and it may just be helpful, I think that's okay. But you stop that typically when you're about 36 weeks because you want to not be blocking your opioid receptors when it comes time for labor. Because let's say that you want something like an epidural. Well, if you get an epidural and we are blocking your opioid receptors, then chances are some component of your epidural is not going to work. I would say it's okay, but there really isn't sufficient evidence out there to say that it's helpful, although it's probably not harmful. Hello to Sing Party of Three. I do like that name, Party of Three. Sharmila asks, one of my friends has an AMH value that's 5.8, and they got scheduled for an egg retrieval process, but I'm concerned that she might have PCO without ruling it out. They're planning, and she's having 30 plus follicles. So, yeah, I would say absolutely right there. When an AMH or an anti-Mullerian hormone level is above about a 5, then we believe that we will predict that the ovaries are going to respond like polycystic ovaries. So let's talk about really what that means. First of all, what is the AMH hormone? You know, we can't actually measure the number of eggs in the ovaries because there are millions of them. Even in someone with a low AMH, there's still probably, millions, at least hundreds of thousands of eggs. So we can't see those eggs by ultrasound. They're microscopic. But since you're born with every egg that you'll ever have, unlike the sperm that comes out today, which are produced in his body about 3 months ago, there are some cells that surround each of those eggs. And those cells make anti-Mullerian hormone, or AMH. The more of those eggs you have, then the more of those cells you have. And the more of those cells you have, the more AMH you have. So we can check your AMH level and sort of plot out on a graph where you are relative to other people of your age. So we know the body ages. We can see how is the ovary aging as well. And that's really what the AMH is for. It gives us some ability to predict how your body will respond to hormones, respond to stimulation and to treatment. So it suggests polycystic type ovaries, meaning to say that the ovaries are going to pay really close attention to the medication. And if they pay really close attention to the medication, you're going to make an awful lot of eggs. Is that a problem? Well, it could be, because the more eggs you make, then the greater the probability you fall into what's known as ovarian hyperstimulation syndrome, or OHSS. That's something that we really don't want. We in my practice and in many practices, we follow you very closely so that we can avoid the OHSS. We don't want that because people can get very, very sick from OHSS, and bad things can happen to them. With many follicles like that, I'd say, Sharmila, your friend is definitely at risk for OHSS. The other thing that happens there is when you make such a volume of eggs, you're getting potentially quantity over quality. And really what we want is the quality of eggs, not the quantity of eggs. It'd be nice to have a little bit of both, but by 30 eggs, you're really getting more than what you probably really need in order to achieve an outcome. Now, I say these ovaries may behave like polycystic ovaries, and in other words, they will respond very well to the stimulation. But polycystic ovarian syndrome is a different animal, really entirely. The syndrome is where you've got these ovaries that tend to respond this way. Many of the people with PCOS have chronic anovulation. They may not release an egg in a predictable fashion every month, and they have some particular laboratory type abnormalities. They've got problems with their insulin resistance. They are resistant to their own insulin. Or two, they have issues with their androgens, which are the male hormones. And with those male hormones, that can cause things like hair growth where you don't want it, and hair loss in places where you do want hair. So that's the difference between what I consider polycystic ovaries and what we call polycystic ovarian syndrome. But yep, you're right. With an AMH above a 5, we start thinking that's how those ovaries are going to respond. If you are just joining us, we got about 20 minutes left in the program here. This is Fertility with Fink. I am Dr. Randy Fink in Pensacola, Florida at New Life Fertility. We also have offices in Dothan, Alabama, Mobile, Alabama, Tallahassee, Florida, and Panama City. And yes, indeed, we do see patients from all over the country. This is a nuanced type of fertility practice, a boutique practice that is still far less expensive than the average, about 50% actually less than average cost for IVF, but where we can pay very close attention to you and walk with you through every step of the process. So if you're struggling, we are here for you, and I am always happy to help. Oh gosh, April says, is there any additional supplement needed for twin pregnancy versus a singleton? Calcium, iron, folate. Well, as you get more pregnant, you will find there is a greater probability of developing anemia. So that's a realistic concern. Your calcium needs do go up a little bit. So, and as does your calorie need in a pregnancy, in a twin pregnancy. So I think it's a very good question. Typically, a prenatal vitamin should be adequate, but usually I do recommend a little extra calcium, and want to pay kind of close attention to your diet in terms of your calories and the amount of weight that you will gain as it pertains to the babies growing. A very special hello this evening to the one and only Timothy Sean Abel from Hollywood, California, one of the world's finest actors, of the famous Dirk Erken Schmirk team. Tim is not only a rock star. Actually, I don't know if you play an instrument at all, but he is a superstar in the world of entertainment, and is a wonderful, handsome man. He says, Dr. Fink, handsome as ever, especially when discussing fertility. You know, handsome there, T.S. Abel. Thank you very much for being here. Good to see you, my friend. Thanks for joining. Hey, also to Sheila 125. And let's see, what else can one do to get pregnant and carry to term when everything is normal, but still no success? We want to look under every stone. I think it is worthwhile, certainly, to have a hysteroscopy to look inside the uterus, to look at a bunch of different things in the blood. So the American Society for Reproductive Medicine, the ASRM, does have a particular set of guidelines for recurrent pregnancy loss and for recurrent implantation failure, particularly when you have implanted more than one euploid embryo. Now, again, we think that most of the time it turns out that these are embryo issues, even though we may not be able to identify what was that specific issue. but I think that whole evaluation is really very worthwhile doing to see if there's anything in your body that may be contributing to the process not being able to continue on. What do you do to keep yourself sane in these difficult times? Many people journal. Many people resort to taking a vacation, going away, going someplace else. Sometimes we call that a procreation vacation. Not that procreation necessarily happens on that vacation, but it's just good to get away and let your mind go someplace else so that the worry does not plague you here. What do you do? You know what? And maybe since I don't know that we're going to get to all those answers here on the show tonight, but so if you've got a particular thing that you'd like to share with the rest of our audience, what do you do to keep yourself sane during these times of trial? Please email me that, would you? Because I'd like to discuss that next Tuesday when we get together. I'd like to know what everybody thinks. Email me at askfertilitywithfink at firstfertility.com. Ask Fertility with Fink at firstfertility.com. And I think that's something that would be well worth sharing. I have some personal things that I'd like to share with you. Why don't we make that a good topic for next week? What can we do to keep ourselves sane during these difficult times? Please email me your response. I would appreciate that. Hey, Noodles for Life. Allie and Kowser, the Stiles family, thank you for being here. Holiday Homemaker. I was taking Clomid with Stim, so could that lower my estrogen level? Yes, Clomid also does lower an estrogen level. The thing about Clomid is that Clomid also has an effect of blocking estrogen at the level of the uterus on the inside where the embryo implants. So the endometrium will often get a little thinner than it otherwise will be because of that anti-estrogen effect from Clomid. So yeah, it can be a thing there for sure. Chalisla Fresa is what that says. Hi, Ramir Sue. Shanna says we have a day 3 embryo, so not genetically tested. Does the 95% success rate once a heartbeat has been heard still apply to day 3 embryos? Well, I would say the answer to that is yes, because once we see the heartbeat, again, 95% of those pregnancies will continue. The issue is that with a day 3 embryo, we can't say too much more about how healthy that embryo really is and how healthy it will be on the inside. There are many people that say, well, gosh, if we put an embryo in you, certainly if it's a normal embryo, it's going to grow inside of you, whether it's a day 3 embryo or whether it's a blastocyst. But what we know is that there is a higher ongoing pregnancy rate in a blastocyst embryo or a day 5, day 6 embryo, a higher ongoing pregnancy rate. And that still applies even though you saw a heartbeat with your day 3 embryo. Really, it does suggest to me that this is an embryo factor and not a mom factor. And that's a really important thing to know, because once you have suffered through the loss of a pregnancy, every day that goes by in a subsequent pregnancy, you're asking yourself, am I okay? Is this going to work? And it may not really even take until the next pregnancy. You're going to ask yourself right now, did I do something wrong? And the answer to that is no. There's nothing that you did that would cause a miscarriage or pregnancy loss to happen. There's no amount of having intercourse or being next to someone who is smoking a cigarette or having a sip of wine before you, or even a glass of wine before you realize that you were pregnant. There's nothing about the exercise. There's nothing about the travel. There's nothing about the stress. It was really destined to happen from the time that sperm met egg. So, but what it does tell me is that things actually work right in your body. You have the ability to implant a pregnancy, and that pregnancy has the ability to grow. So again, it really does suggest that there was an issue with your embryo, not so much an issue with your uterus or your system in the way it was able to hold on to that pregnancy. And I wish I had said that before so that my answer to you wasn't so disjointed, over the course of 45 minutes. But I hope you'll forgive me for that, because I think it's a very important thing for anyone with a pregnancy loss to take away. Kowser 8194 said, we had planned for IVF earlier, but we delayed due to a 3-centimeter cyst, and the period is almost 3 weeks delayed, and now I'm advised to take estrase and Provera for 1 week to resolve the cyst. Is this right? So really what happened there is that you had a space-occupying cyst in your ovary. What was that cyst? Well, they can be a lot of different things. And in most cases, they're really just kind of a leftover space that was left behind from something that was happening in your prior cycle. Sometimes they are what we'll call an anovulatory follicle, or it is a follicle that has an egg that's not going to get released, and that sort of thing can happen. When they're in the ovary, kind of what's happening there is that they're taking up valuable real estate, real estate that the rest of the ovary really wants to be able to use in order to make eggs. So when a cyst is 30 millimeters or 3 centimeters, we really want that thing to go away. Sometimes those cysts are also manufacturing hormones. And if that's the case, boy, they can really stand in the way of the success of an IVF cycle. So sometimes what happens there is that we'll put you on a little birth control. If we put you on birth control, it suppresses what's going on in the ovary and will ultimately allow a functional ovarian cyst, that is a follicle that's making hormones, to disappear really on its own accord. When you're using estrase and Provera, you're essentially using the same hormones that are in birth control. So what's birth control? Birth control is estrogen and progesterone. So you're using estrogen and progesterone to try to let your ovaries calm down and let that cyst start to resolve. Now, in my opinion, doing that for 1 week is likely not going to be sufficient to make a 3-centimeter cyst go away. You may see it going in the right direction, and that's certainly a plus, but it probably will not resolve over 1 week's time of that hormone suppressive therapy. If you get a 3-month Depo-Provera shot, should you wait 3 months prior to the next transfer? Could you proceed to transfer in 2 months? You could. Yes, you can. So there are some transfer protocols, and in fact, that's one of the things that we do here. And folks who have an issue with recurrent implantation failure, we will keep you on some Lupron while we are giving you the estrogen and the progesterone, so that we are completely being the source of all of your hormones. The Lupron is shutting it all down, and we're giving you all the hormones. So yes, you can do that. That's going out to Shada, because in that scenario, you may be more apt to say, if we control it completely, maybe we can take away any variables that might be causing these embryos not to continue to grow. So yes, you can get the 3-month Depo shot, and then in 2 months do a medicated cycle. Obviously, it has to be a medicated cycle because your own hormones are going to be shut down. They're not going to be doing anything. So we can give you those hormones while the Depo-Provera keeps your body from making any of the hormone on its own. Hi to Claudine and Linnea. Thank you for being here. Bam Miguel, my beautiful mother, and my father not far from her side in Mobile, Alabama. They are not too far from me now, and that makes me happy. It is good to see you on the program tonight. They are not always so good about figuring out how to get onto Instagram and how to answer texts and how to do things like that. Mom, I'm not going to make fun of you in front of everyone else, but let's just say I wish we could set up something so all you had to do was push one button, and there you would be on the show. Thank you for being here. behavior. Chef Blackney, hey, how are you this evening? Sarah Elizabeth, hello. I am 12 weeks pregnant with triplets. Oh, my heavens. Yes, an egg split. When should I stop the PIO? I am so scared to just stop them this week. Well, at this point, my friend, you've got 3 times the placenta there, or at least 2 times the placenta probably, that is making progesterone. So at this point, you do not need to still be on progesterone anymore. You should have plenty adequate progesterone. I have not seen a situation where by 12 weeks, a placenta is not making sufficient progesterone to be able to maintain a pregnancy, just because that's what it does. I mean, that's why it exists. It exists for the very reason of making progesterone there. So you got your hands full there, my friend. Congratulations, times 3. I guess you're saying one of those eggs split. So it sounds like you may have put in 2 embryos thinking that, well, okay, we're going to, maybe we're going to get twins here. Well, both of those eggs, or rather both of those embryos stuck, and then one of them divided again. So that means one set of identical twins, and the third will be a fraternal sibling. So congratulations there. Very exciting news. Let's see. Hello, New York baby DJ. I haven't seen you for a while. Thank you for being here. Chef Blackney asks, hello, Dr. Fink, and hello to you. For women who are 40, do you recommend a day 3 or a day 5 embryo, and why? So this is a source of much consternation in the world, because there really isn't a single good answer to that question. So let me tell you both sides of the equation there. On the one hand, many people feel like if you have a day 5 embryo or a blastocyst, so we know that as an embryo grows, it starts out as 2 cells that come together and they make a little embryo. Those 2 cells divide and they become 4 cells. 4 cells become 8 cells, and then it keeps on going from there. So a day 3 embryo is what's known as a cleavage stage embryo. It is still just trying to figure out how it is supposed to grow, how it's supposed to divide, how it's supposed to survive. Its sole journey in life is making those cells divide so that it can continue. A blastocyst, on the other hand, or a day 5 embryo, is an embryo that has figured that process out. It's probably 150 cells by that point, and it has become a little functioning metabolic factory. So we know that when we place a blastocyst inside of you, when you transfer a blastocyst embryo, it has a higher probability of being able to get you a baby, because that blastocyst or that embryo lasted a little bit longer. It passed that milestone and made it to the point where it was actually feeding and growing. A day 3 embryo, we don't know whether it's going to survive to that point. So some would say, I would rather put a blastocyst embryo into you because I know it has a higher probability of working. And let's say you do 3 or 4 transfers and none of your day 3 embryos work. I can't really tell you much about the embryos themselves. Was this an embryo problem? In all probability, but can we say for sure? Well, we don't know, because they didn't make blast, and so we can't do chromosomal testing on them, and we don't know if that embryo would have otherwise survived. Now, the flip side to that is that a uterus is always going to be a better incubator than really anything we have in the laboratory. And why is that? Well, for one, that's what the uterus is there for. That's why it was built. That's why you carry one around, that as an embryo grows inside of you, all the metabolic byproducts, the waste product, and even think about this, even some little tiny cells kind of pee and poop. Not exactly, but they have metabolic waste to them. And so when that's in the laboratory, that waste stays in the little petri dish. Now, the media that those embryos are in may have some ability to help rid the petri dish of that waste. Or sometimes the media has even changed to help rid of that waste. But there are some people that feel like the uterus does a better job of that than anything that we could do in the laboratory. So, especially for an older woman or someone that we would call advanced reproductive age, which is 40 and older, we'll say, that a day 3 embryo, you transfer multiple day 3 embryos, they're not all going to work because they're day 3 embryos. And so just chromosomally, they are less likely to be normal given the fact that you're 40. And we don't know, again, that they, how they're going to survive. But if you have one that is normal, that it may be more likely to survive inside of you than it would potentially in the laboratory. And I think there may be something to that, but again, it's highly controversial. Is there a problem with transferring day 3 embryos? And the answer to that is no, there's no problem with it. The only issue is you're going to end up having more potentially unsuccessful transfers just because we don't know really anything about the quality of those embryos. So at 40, I'd say day 3 embryos are fine, but I think I would, to increase the probability of pregnancy, I would recommend transferring more than one day 3 embryo if you're 40 years old. And that's kind of the my scheme for getting situations like that pregnant, if the practice will allow for it, is to put multiple day 3 embryos in hopes that one of them will stick and do better inside of you than it might otherwise do in the lab. But again, be aware that there are many practices that don't believe that. And since unfortunately we can't live in those petri dishes, we don't know what's going to happen to them. Gosh, folks, it looks like we are going to be out of time here tonight. So I sure appreciate everybody being here. It is such a pleasure to see you all as we are here every Tuesday evening at this time. Please remember it. Well, first of all, if I didn't get to your question, email it to me. And I do want to know your answer. What do you do to help yourself through these difficult times? And we're going to talk about that next week because I do have some very personal suggestions that I would like to share with you, things that have been very meaningful to me that I hope will be meaningful to you. Gosh, this whole fertility thing is not the book of your life. This is just a chapter. What are we here to do? We're here to rewrite the kindness to others around you because the world is short on kind these days. Step forward with love. Never know tomorrow is a new day, and with those new days come all new adventures. Until next week, I'm Dr. Randy Fink. Thanks for being here. Good night. See you later.